Hello, in this episode we'll discuss vaginitis and vaginosis. First, let's describe the process of normal vaginal pH production. Remember, estrogen promotes a pool of glycogen storage within the vaginal epithelial cell that is utilized by lactobacilli and produces lactate. This acid produces an acidic environment with pH less than 4.5. That's the normal vaginal pH. That's defined as 3.8 to 4.5. And this functions as a protective mechanism against bacterial infection. Now, in this episode, we discuss the bacterial, fungal, and trichomonial causes of vaginitis and vaginosis. However, you need to know that there are some non-infectious etiologies. Can you mention what could be the cause in these cases? In a postmenopausal woman with vaginal symptoms such as pruritus, we think of atrophic vaginitis. How about the most common cause of irritant vaginitis? It could be due to frequent douching. Never forget, foreign bodies such as tampons and condoms can also cause vaginal irritation. And finally, dermatosis and some systemic illnesses could be associated with vaginal symptoms. The second background information we need is to be able to differentiate inflammatory versus non-inflammatory symptoms, because bacterial vaginosis is not an inflammatory condition. As you can see, the name is not vaginitis, and that means that even though the patient has discharge and irritation and odor, the symptoms of inflammation will be absent. So what are the symptoms of inflammation? Burning sensation, erythema, and pruritus are the most important ones, but also dysuria and dyspareunia are possibilities. Also, remember that vaginal symptoms are usually categorized into vaginal lesions or external genital lesion, which are STIs, or discharge that could be STI or not a STI. What do you expect to see the vaginal pH in bacterial vaginosis? Because anaerobe Gardnerella vaginalis outgrows lactobacilli, we have less lactate production, and therefore pH would increase to values greater than 4.5. What are the risk factors of bacterial vaginosis? Always remember, pregnancy, multiple sexual partner, female sexual partner, smoking, and frequent douching are the risk factors. Once more, what are the symptoms of bacterial vaginosis? Malodorous, white-gray, thin vaginal discharge. Always remember, symptoms of inflammation such as dyspareunia, pruritus, and erythema are absent. How the malodorous discharge is described? Fishy or stale odor. What are the possible complications of bacterial vaginosis? Endometritis and pelvic inflammatory disease, chorioamnionitis, and preterm deliveries. Describe the lab assessment. We have wet mount or saline microscopy office test, which shows clue cells on at least 20% of vaginal epithelial cells. What are these clue cells? At least 20% of vaginal epithelial cells that are covered by these gram variable rods. What are the other office tests? We have potassium hydroxide or amine or whiff test, in which volatilization of amines by KOH produces a fishy odor. And if you are asked about the presence of PMNs, the neutrophils, remember that the normal vaginal ratio is maintained. That is, a neutrophil to epithelial cell ratio is still less than 1. And another question is, do we need culture? The answer is no. Likewise, do we need to treat the partner? The answer is no. Now, this is very sensitive issue. Remember that even though sexual activity is associated or is considered a risk factor for bacterial vaginosis is not considered an STI. And what's the treatment? Either PO or vaginal metronidazole or clindamycin. Metronidazole gel could also be used, and the treatment course is 7 days. Now, let's turn our attention to Trichomonas vaginalis. What's the most important risk factor? It's sex with multiple partners. MP here does not stand for Member of Parliament, but multiple partner. Now, what are the other symptoms? Here, not only we are dealing with the symptoms of discharge, that's malodorous, with irritation, but we do have symptoms of inflammation. So we have pruritus and dysuria, and specifically we have profound vulvovaginal erythema that is referred to as strawberry cervix. Every time you hear strawberry cervix, remember postcoital bleeding could be also present. Now, what are the characteristics of the discharge? Discharge is still malodorous and thin. It could be profuse, however. Remember that thick is specific for Candida. So here we could have thin or profuse, but not thick yet. And the color is green to yellow. What is vaginal pH of Trichomoniasis vaginalis infection? pH is even greater than what is seen with bacterial vaginosis, and it reaches values more than 5. What do we see in wet mount saline microscopy? We see motile flagellated protozoans. Remember I mentioned the polymorphonuclear ratio to epithelial cell is still less than 1 in bacterial vaginosis. Now, what is that value in Trichomoniasis vaginalis? We have multiple polymorphonuclears. Whiff test could be positive or negative, so remember a whiff test is not specific for bacterial vaginosis. What are the treatment recommendations? Treatment could be either a single dose of metronidazole or tinidazole, PO, that's usually 2 grams, or it could be a 7-day course of 500 milligram BID metronidazole tablets. Don't forget to treat the partner. We are dealing with an STI, otherwise we will have the ping pong effect that the infection goes back and forth between partners. Okay, let's turn our attention to the vulvovaginal candidiasis. What are the risk factors? Think of immunodeficiency states such as pregnancy, diabetes, use of corticosteroids, and HIV infection. Think of use of antibiotics or OCPs. Think about tight-fitting clothing or increased frequency of sexual activity. So you can see there's definitely an element of physical, frictional trauma involved. What are the hallmarks in terms of clinical findings that help diagnose the vulvovaginal candidiasis or differentiate it from other vaginitis? Remember, again, as I mentioned, the discharge is thick and curd-like and whitish. More importantly, contrary to Trichomoniasis and bacterial vaginosis, the discharge is odorless. Inflammatory signs are present, such as pruritus, erythema, dyspareunia. However, remember, excoriation of vulva or vagina and very intense pruritus could be the clues for diagnosis. Please be able to distinguish rash, excoriation, and fissure from ulcer, because ulcer brings us to a different set of differentials such as syphilis, HSV, etc. Here we are dealing with excoriation and erosions. Now, returning back to our lab assessment, what is the pH? pH is normal vaginal pH, and that's less than 4.5. Remember, this is the only one among the 3 major causes of vaginitis that has normal vaginal pH. Now, when it comes to wet mount or KOH office tests of vaginitis, we have saline wet mount, and we have KOH wet mount, and we have the whiff test. What's the difference is what matters. Remember, the previous ones, the bacterial vaginosis and Trichomoniasis vaginitis, could be identified with saline wet mount with microscopy. Whiff test was the smell when we apply KOH to the vaginal discharge. But in the case of Candida vulvovaginitis, we need KOH, not saline, but KOH wet mount. That is the liquid that we put on the slide is not going to be just saline, it's going to be KOH. Why is it so? Because that helps visualizing the fungal elements such as budding yeast or pseudohyphae of Candida. This has higher sensitivity than simple saline microscopy for assessment and diagnosis of Candida. Now, among the 3 elements, budding yeast, hyphae, and pseudohyphae, which one could specifically be visualized by KOH wet mount? That is the pseudohyphae element. What's the treatment? We use azole antifungals either as vaginal suppository of miconazole or a vaginal tablet of clotrimazole or a single oral dose of fluconazole. So in summary, you have a patient with one of our risk factors. Remember, vaginal douching and female partners are specific to bacterial vaginosis, while immunodeficient states or recent use of antibiotics favor candidal vulvovaginitis. Then pay attention to the pH. That's normal only with candida and increased with the other ones. Pay attention to the discharge. That would be frothy or profuse or green, yellow in Trichomonas. It could be curd-like and thick without bad odor in Candida. Treatment is metronidazole for bacterial vaginosis and Trichomonas versus azole antifungals for Candidiasis. Don't forget the inflammatory symptoms are absent with bacterial vaginosis and we do not need the partner treatment. Don't forget strawberry cervix with Trichomonas. This finishes our discussion of bacterial, trichomonal, and candidal vaginitis and vaginosis.